Good afternoon, Dr. Salem.
Hey, great to be here. Great to be here with both of you here today. And I know Ari's going to join us in a little bit. How's
Absolutely.
everything going on your end?
Fantastic. I was just talking to, is it pronounced Adeleye?
Yeah, I say Adeleye, but I really go by Amanda, honestly.
Okay. Well, thank you. We'll call you Dr. Amanda.
Sure.
I was just telling her, really looking forward to this. I feel like a lot of people miss the mark on some of this stuff. And I know some of you and I, like we talk about the increases in like sperm costs for LGBT communities and how, it's getting to almost out of control now. And it was interesting. I actually did some research into this to figure out like what's causing that. And so, like I said, it's gonna be a really fun discussion. I hope we get a lot of people on to that tonight to, kind of interact with us. So
Definitely. And just a quick intro. I'll do a quick intro for you, Doctor, and maybe you could introduce yourself because I think a lot of our viewers would love to know who you are. So, and I'll call you Dr. Amanda as well. So, Dr. Amanda, of course, double board certified OBGYN and REI practicing in Chicago, formerly in the academic world at the University of Chicago, and then now transitioning over, of course, working and launching a practice with CCRM. So please introduce yourself as well. There's so many more accolades, so many more things I could say about you that won't do you justice, but give us your version.
Oh, you're too kind. Yes, I'm a reproductive endocrinologist and infertility specialist. I'm from Illinois. I did my medical school training and residency at Columbia, and then I did my fellowship at University of California, San Francisco, and then I was faculty at the University of Chicago for several years before joining my current practice, which is CCRM. So that's my academic background, but I think more importantly in that journey, I did really get great exposure to really the challenges that people face on their reproductive journeys and how it can be different depending on how you identify. I have an interest in transgender fertility care that kind of started back in medical school. And, I've been interested in healthcare disparities for many years across the board. And so my journey has allowed me to kind of see across the country how fertility care is received and those differences and how we can make it better.
That's awesome. Yeah, that's something that's, I know, near and dear to our heart as well, and something that we've all lived through, seeing fertility care. And I think, one thing I'd love to touch on today is just like this concept of like, do disparities exist? I think we all kind of know the answer to that, but it's important maybe for some of our viewers, people out there. And then the more important thing is, what the heck can we do about it? How do we make it these disparities, go away and everybody gets excellent care? But yeah, Dr. Amos, what are some things that like, and as you've practiced over the years, you've set up this practice, that sees people from, all walks of life for all many different reasons. I mean, what are some of your takes on kind of how you've seen this play out over the last decade?
Yeah, I mean, I think there's a lot of parts. I'd love to figure out, Dr. Amanda's point of view. I mean, obviously, when you're talking about marginalized communities, there is some financial portion to it. So, we know that IVF has been out of reach for many, many people. And I know with our practice, we try to be a little bit more affordable. We're able to maybe financially be available for people, but there's still other obstacles for them to get here, right? Trust for doctors. Do they feel comfortable coming there? Where is it located, right? Is it located on, what part of town and stuff? So it's interesting. I did notice myself that when we opened our clinic, I felt like some of the communities were coming to us that I never saw before in other practices. Where it was kind of, as they say, bougie. I might be using that word wrong, but it felt like I was seeing people that normally wouldn't. I was in another practice, and so there was definitely that financial component. The question is what is the other component, and how do we get that trust? And that's the part I think that's important. And I don't think it's just the doctors. This is the thing I was going to tell you, Dr. Mann. I had this this company come to me who sells, medications, and they said, I won't name the company, so I won't be mean to them, but it was one of the meds that we use, a big proponent. And when they came to me, they were saying, "Oh, we really want to help these communities." I said, "Well, that's fantastic." I said, "So what's your plans?" I said, "You guys are going to lower the cost of your meds, right?" They're like, "Well, no, we're not doing that. We thought we'd just educate you more." I said, "I appreciate that's part of it." But I feel like finances are a big part of it too. And I don't understand, like, are you just, what are you doing here? Are you really caring, or are you just trying to put on this front, And it was
Mhm.
what you think about that, because I do know that a lot of, sorry, I do know that a lot of people, we do focus a lot on the financial side, but that's not it, because I know, because we're very affordable, and that doesn't mean we have our door being knocked down by every marginalized community. So
Yeah, I think you're right there. I mean, in my view, and it aligns with yours, there are so many barriers to care, right? There is the educational barrier. Do you recognize that you have fertility issues or that you need assistance? And that's something that I feel like is kind of low hanging fruit. So that's where I've sort of built a niche. But then there's, kind of regional accessibility, technologic accessibility. Since COVID, a lot of folks have gone to virtual consults, which in some regards has really kind of expanded access. But in others, if you don't have a good working computer, you don't have access. So there's technological accessibility, then certainly financial accessibility, and that's all before you even walk in the door. And so, to your point about, well, an unnamed, company, wanting to sort of increase educational awareness, and how genuine is that? I do genuinely think that, education's a pretty important component to it. So I'm sort of like, bring everybody in and we can kind of continue a conversation about, the affordability aspect of it, which is ultimately probably the biggest barrier for care.
So
absolutely.
one thing I'm really curious about, and I'd love to get your guys' like thoughts on this, because we talk about disparities, generally, broadly, but there's many groups within that. And I'm just curious what you guys think are the groups in which we see the biggest disparities. I mean, I know there's there's no way to compare these things, but if we were going to have a mission and we were going to say, okay, hey, the mission is to address the group that is most being negatively affected by not having access to good reproductive, especially IVF care. That's what we do. We do IVF. That's mainly what we do. That's mainly what I'm going to care about tonight. There's a lot of other types of reproductive care that other people are going to be much better at talking about than we are. But are we talking about, racial inequities? Are we talking about socioeconomic inequities? Are we talking about different types of like same-sex couples, single motherhood by choice, same-sex male couples? Like, where do we find that there are the biggest disparities? And are these things that our field is well equipped to address as it currently stands?
I have thoughts, but
Too fast, guys.
Well, I was going to let Dr. Amanda speak first.
yeah, sure. I mean, I think you nailed it on the different, a lot of the different groups. I mean, I think it's important to, recognize that like one identity isn't, your only identity. And most people would say like, oh, like, being, Black or Hispanic, like, we're not a monolith. And I think that kind of goes for really any group. So I think when we're talking about this, we have to just be cognizant of that. And really there's like an intersectionality to think about with a lot of these groups. But yeah, so, when it comes to presenting for care, we know that people of color, particularly Black people, present about 20 months later than their white counterparts for initial fertility evaluation. Once they're in the door, they are underrepresented relative to their white counterparts at kind of every step of the journey. And then if and when they do make it to something like IVF, unfortunately outcomes are poor, and despite potentially even having higher egg yields, the, embryo yield, blast rates, implantation rates. Those are all lower in people of color, again, amplified for, Black identified folks. And then miscarriage rates are higher, which is something that I've been more interested in lately. And second trimester loss rates are higher in people of color. Altogether, that leads to lower live birth rates for people of color undergoing IVF. When it comes to the LGBTQ plus community, I tend to think a lot about the sort of financial accessibility. I mean, it applies to everybody, but there are sectors within the LGBTQ plus community who might be more socioeconomically advantaged compared to their counterparts, but that doesn't always translate into like increased access to fertility care. They can often be stigmatized. And I do know there are practices out there that won't treat LGBTQ plus folks, unfortunately. So there's certainly an access component. I think in terms of regional limitations, there's a great paper. It was actually focused on fellowships. It came out in the Journal of Assisted Reproductive Genetics, I believe, Diego et al., 2020, 2021. I forget exactly when, but it's great. It has a nice map in there that shows, really the distance that the average reproductive aged woman needs to travel to get to a fertility clinic with an IVF lab. And I believe it's somewhere around, like, don't quote me on this, 20 to 25% of folks live more than 2 hours from the nearest IVF clinic. So we definitely have, disparities in who gets to be seen and when, and most fertility clinics are concentrated in the Northeast. So those are just kind of a few disparities we could start off with, but there are more. And again, people kind of cross identities here and can kind of touch on this in many ways.
It's interesting because, I've had like doctors who come through who, may be Hispanic origin. And, when we talk about this kind of idea of disparities, like there's these stereotypes where I remember one of them said to me, like, why am I having these problems? I'm Hispanic. I'm not supposed to have problems. And it just shows that kind of stereotype that we have in society that, like, oh, people of color don't have problems having kids, and so, do you think that some of those stereotypes might affect people, come to see a doctor, like, is there something wrong with me? Like, this isn't my culture. I shouldn't, be having problems. It'd be interesting. Like I said, it's something I'm learning a lot about. My big area I want to talk about at some point tonight is gay men, because I feel like they are probably, of everyone, has the hardest time for fertility, just because of the expenses and things like that. But what are your thoughts on kind of the social construct of how people feel, in their community? Do you think that has a little part to play in it? Do you find that when you talk to people?
Oh, for sure. I mean, I think it's a big part of it. Within communities of color, particularly within like Black and Hispanic communities, there's this concept of like hyperfertility, right? Which really, unfortunately, at least for Black folks, kind of goes back to, the times of slavery and, Black people being, treated as though they could be breeded, right? And it's awful, but like those sorts of concepts have kind of continued even into the 21st century. And so yes, I've definitely seen it in my office. I've seen it in talking to folks, being at predominantly Black churches, and just having conversations, and people, just like you said, thinking, oh my gosh, I thought I was so fertile, but in fact I have a really significant issue. So that's unfortunate. There's also really social stigma and pressure, and it really isn't limited to to people of color. I think it's a problem in lots of different communities, but in different ways, where people don't really want to talk about their infertility experience. And it brings shame, and like, especially I find in some communities, male infertility is a real issue, right? Where people like being fertile as a man, it's like as equivalent to your virility. And so, if there's any question there, right? Like these men are crushed in the office. I'm sure you guys have seen it too. If this human analysis isn't perfect, and so I think that's another kind of cultural challenge for sure, is just even having a comfort level within your community to have conversations about your fertility issues.
Yeah. I feel like that is such a big barrier, right? Like I think like for me, that's a really big one. I think there are certain communities that have a really hard time coming in through the front door, even when they have access. I remember actually, in places that there's been a lot of published work out of like Massachusetts where they say, hey, listen, everybody has access to fertility benefits because it's a mandated state, of course, same in Illinois. And yet we're seeing this disparity. There are more, white folks as opposed to black folks that are getting into the fertility clinic by the percent that we would expect. And not only that, but they're not continuing care or, not going on downstream. And so, on that same note, like, what do we tell our patients, or what are our patients actually telling us about why they're not coming in? I mean, what's the big barrier there, and what can we as a field do to rectify this, to improve it so that people feel more welcome coming in? Or is this a cultural thing that has to be, addressed in the barbershops and addressed at home, addressed at Thanksgiving before it ever gets to a fertility clinic?
Do you remember in Rochester when you were there, Salem? This was very common in the Smalling community. Where, I mean, again, it was more of a cultural thing than because of a person of color. And, they would come in and, I mean, say, don't tell my husband, like it was this real shame to not be fertile in certain communities. And so you're right. I mean, I think there's so much to it. It's not just, as you mentioned, it's not a monolith, that there are other things going on here. But I definitely love to see, Dr. Amanda, like, how can we, not saying we as white Caucasian doctors, but just as a community, what things can we do to maybe, have you found in any of your studies or any of your work to help, certain communities that are in that culture of shame, of not being able to get pregnant?
Yeah, I mean, I think as providers, we can try to humbly enter those communities, and where there are opportunities to speak and educate, like, do it. Like, as an example, like, I am, a straight cisgender woman, like, and I've been that way, as long as I have had that identity, right? But I have a particular interest in the LGBTQ plus community. And like, I certainly don't pretend to like know all the nuances within the community, but there's a local, larger LGBTQ plus primary care clinic in Chicago. And so I've been working with them for years because like, I just think that it's important to reach out to that community and to like build understanding and to do research in that community, and to kind of be able to uplift their reproductive opportunities. And so, I like to watch RuPaul's Drag Race, and sometimes there's like a documentary about being trans, or certain books, and try to like read it and be there and have those conversations. But also, as I encounter folks that would identify as part of that community, I try to stay humble. And the fact is, I don't know that experience. Like, I'm trying to learn. They're not there to teach me, but at the same time, if something comes up, I don't know, I can ask. And so I think across our REI community, maybe that means going to a synagogue and, just hanging out. Like, if they have like an open, Shabbat dinner, go like see if you can go, if there's a community one, and start talking to people. And I think, just like kind of the classic OBGYN who used to kind of have their panel of patients and go deliver all their babies and all of that, and like truly was a part of the community. I think as REIs, we have to pull away from this sort of concept of a boutique experience for these like very wealthy people and really say, no, we are here to serve the community, whatever community that is. And And I think conversations like this that you're having are like a great step in that direction.
Yeah.
It blows my mind when you said earlier that there are doctors who won't serve the LGBTQ plus community. I mean, that's shocking at this point. I feel like you think that would be weeded out at this point.
Right.
So that's really shocking that they even exist. I don't know of any. I know there was a person in our town at one time, and they changed their policy. But like I said, I don't actually know of any others. So that blows my mind. That's what you're talking about, opening up minds and talking to the other doctors in our community. What about, like, what steps could we do in the RI community right now, like, other than going to places like you said? Do you think that might be able to help us get people to trust the RI community a lot? Because there's a lot of money too, right? I mean, when you talk about, you look at some studies, I mean, they show that certain communities don't trust physicians. And now you're saying, okay, and I not only want you to trust me, but I also want you to give me a $20,000 payment. What do you think? I mean, because I have noticed sometimes that there are certain communities that they aren't very trustworthy. And when things don't work, they almost feel like you cheated them. Even though, obviously, I mean, I do anything to make it work 100%. And so what could we do in our communities, meaning the RI community, you think, to help lessen that fear of that doctor-patient relationship, and that we're really here to help? We're not trying to take advantage of anything.
Yeah, that's a tough one. I definitely have an interest in patient education, and that with that comes, really build trust, as you've mentioned. And I think kind of globally, forgetting any specific identity, we're really at a turning point within the medical community when it comes to like distrust of the medical community. I mean, if you think about the measles outbreak that started in Texas and has really started to spread, and like part of that is because, I think that there's a lack of trust in the medical community about, when we say that vaccines are efficacious, like people today in 2025 don't believe us when we say that. And so honestly, I mean, I'm a little old school here. I think part of the problem is, I think, especially when we engage with the media, or when the media tries to tell these stories of building sort of these equivalencies, like two sides of a story or multiple sides. It's like, actually, like, that's the beauty of science, is like, it's just about telling the truth, and I mean, it's hard to know exactly what the truth is, but experiments can get much closer than kind of somebody on TikTok's opinion, and and when they speak in an authoritative manner. So I think, regardless of identity, we have a lot to do as a medical community to restore and repair trust from like what happened with COVID, and also just in the current environment. We're backed in a corner. We have to really start to speak up a little bit more. I think particularly for communities that have been underserved and disserved by medicine, typically, communities of color, but that's not the only group. I think it's about, to some extent, having more providers that look like or identify with the folks that are presenting. There's some good data that outcomes tend to be better when patients, have providers that look like them. Now, the issue is, in those studies, I don't think it's all that, I don't think it's as simple as snapping your fingers and, having, Latino provider in a Spanish-speaking community. I don't think it's that. I think it's, again, there are probably some correlates of somebody with that identity might be more likely to go to an event where there might be lots of other, Spanish-speaking people, and there might be a few phrases or things that they say that they might be more comfortable or aware of, but I really do think it's about investing yourself in the community, and you don't have to necessarily look the same way as your patients to know what they're talking about and where they're coming from, and that trust comes with time.
Yeah,
I love to show the.
Oh my!
Sorry.
I want to unpackage them. And by the way, before I move on, I know there's a lot of people watching here and there, and if you want to jump on and share your story of some experience that you've had with the healthcare system, with a fertility clinic or otherwise, where you felt like, hey, I didn't feel heard or something like that, or something about my
Exactly.
background, my identity played a role in my experience. We'd love to hear it, because that's how we're going to learn and share that story. So if you're comfortable, please come on. But one
Absolutely.
thing that I wanted to, unpack a little bit was this idea of, definitely there's been research showing, hey, if a person goes to a clinic, and especially in the obstetric world, we've seen that with maternal mortality stuff. Um, a patient goes to a provider, especially an OBGYN, who comes from their community, or let's say looks at least a little bit closer to the way they look and speaks their language, they have better outcomes. Now, I'm curious, is it enough for that? Or is it also important to have other people within the infrastructure of that clinic? Or is it more important that there are other people within the infrastructure, whether it be medical assistants or nurses, front desk, et cetera, that, reflect the community, much like you're saying, Dr. Amanda? So like, you know, where is that most important? And I'm gonna say something maybe a little controversial. I think it's more important that the whole clinic kind of reflects, embodies a little bit the whole community. Kind of the people you're taking care of generally look like the people that are working at the clinic, and it's not just like the one-on-one. We'd love to give ourselves more credit, maybe, but I don't know if that's warranted here. I don't know. What do you guys think?
It's actually the question I was going to bring up, this idea of, you know, what is it about that relationship? I mean, clearly just being Hispanic, taking care of a Hispanic patient shouldn't make it better, right? We're all very smart. We all know the same medical information. We all know how to practice medicine. So it's really more about the relationship, right? Maybe there's more trust. Maybe there's more um they're getting through better. It's kind of like when my dad says something, I'm like, oh, my dad said it, I'm gonna do it. Versus, if someone else just randomly tells me, I go, I don't care what they said. And I wonder what it is. And that's the hard part about science, is that we can find correlations, but they may not be causative. And so, because I can't believe that, someone just as a doctor is better because of, I don't take care of Caucasian people better because I'm Caucasian, right? So, but it's that trust thing, and it's that relationship. And so, yeah, very interesting. I'd love to see what Dr. Mann says about that. What's your thoughts?
Yeah. I mean, I think, like Dr. Salam said, it's interesting. I do think it's important to have a um, a practice that reflects your community. I mean, I think that there's also, I'm not positive on this, but I think that there's some data around policing, um, and that sometimes when the police force tends to reflect the community that they're serving, there are less sort of, um, you know, injuries and assaults on citizens by police officers. And that's because, at the end of the day, you go home and maybe you're neighbors with your police officer, and your police officer knows you and you guys talk. And so, yes, point well taken. And I agree. I think if our whole medical practice, because we really practice as a team, right? It's not just the doctor that walks in the office, it's the front desk, it's the MA, it's the lab director. It's, so many people interact with our patients. And yes, I think if we reflect the community that we live in, that can only help, I think, build trust and comfort. And yeah, I agree. I think it's interesting to see that patients maybe do, better, whatever the metric is in a particular study, when they're in a, racially concordant relationship, partnership with their doctor. I think sometimes, and I think back to, like, I think about when I was pregnant. I have 3 kids, and for each of them, I had some pregnancy complications. And, I do remember being scared and thinking, like, I know the statistics about, Black maternal mortality, and like, gosh, am I going to become a statistic? And I mean, my OB that took care of me was a Black woman. And it did relieve a little bit of fear that I had that perhaps I wasn't going to be listened to, or that if I spoke up, I would be taken seriously. And so, I'm sure there probably are studies out there I just haven't read yet, that are starting to kind of scratch the surface on this. But I think patients might respond differently to providers when they kind of superimpose their fears and think about like how their doctor is going to react to them. And that probably impacts ultimately outcomes. We know if we have a patient who doesn't tell us, the full story, we're missing pieces, we're not going to be able to give them the best diagnosis and the best treatment recommendations. And then that affects them, right? So it's sort of this kind of feed forward loop here. But that's my guess, but I don't really know why racial concordance matters.
That'd be really interesting, like I said, to do that, to figure that study out. And I think the way we're going to figure it out is by looking at, other countries, looking at other situations, and then we can kind of see if we see the same associations at that time. It's just interesting because, obviously my view is only as a Caucasian man. I see any doctor, I see their practitioners, and it never crosses my mind that, at least when I say crossing my mind, meaning non-subjectively, like just in my mind, I'm going, oh, seems like they know what they're talking about. But it's got to be something with that. Because like I said, I know very, very smart doctors, and it doesn't mean they wouldn't be good. And like you said, the outcomes are still different. And so it's got to be some of that relationship. And I think that matters. I saw a patient today who, is in a marginalized community in the LGBTQ plus. And like the fact that they felt comfortable with me, it makes them be able to trust it more, versus if they think I'm judging them or if I'm doing it, I wouldn't trust me either if I was them. And so I do, that's what I think. Now, also, that's my opinion, but I think it's something about that relationship. We have a very unique relationship with patients, and when we're able to get through to them, I think it's able to help their outcomes, make them feel more empowered, make them feel like, okay, they're on this with me versus as just a service.
Mm-hmm.
Totally. And actually, an interesting experience I've had recently that, I think maybe could be illustrative is just like the little signals that we can put around the office that show that we care, even if it's just, the LGBTQ plus and trans, like the trans flag with the BIPOC little triangle, even just like having one of those little stickers can tell somebody like, hey, like I've thought about this and I care. But like, so anyway, so I have this amazing primary care doctor, Dr. Hong. He's great. And I saw him maybe like, I don't know, it was 3 or 6 months ago. And I saw he had, he's at an academic medical center, and he had a little flyer about, it was something about like centering for gay men, right? And again, I do not identify as a gay man, but I saw this flyer. I was like, huh, like that's cool. And I was like, well, tell me more about this. And, he started telling me about the study a little bit. And I was like, oh, okay. Like, I happen to have some patients that, might identify like that as like, is this like a comfortable, safe community? And he was like, yeah, like actually it definitely is. And like lists all the reasons why and the things that he did. And like, let me just say, like, now I'm definitely sending my patients who are looking for a primary care doctor to him because he just like kind of put that foot forward. But I would never have known if I hadn't seen just a little flyer, right? But it's a little extra step that I think can just start to really bring in patients that might be feeling uncomfortable and let them know that you're thinking about them.
Yeah, that's such a great point. Since we're talking about, the gay men and that community, and Dr. Amos, you had brought this up, and I want to make sure we like talk about this here for a second, because I do feel like this is one of those communities that is really disadvantaged. I mean, I don't know what other word to use for it, because ultimately there are some hurdles that are just biological in nature. Like they need a access to a uterus. Okay, so a gestational carrier, a person who's going to be willing to do that for them. Our current environment, that is very, very expensive. They also need to have access to an egg donor, and that is also expensive. They need to have access to IVF, that is also expensive. And so there's this really big, immediately there's a big hurdle just from a economic standpoint. And very interestingly, very few insurances like recognize this or will support it. Some are doing a good job of kind of trying to play catch up here. And um, I think this is just one of these things that in our world, while we see these patients, many of them come to us with a lot of means, quite honestly, and they're able to do all of these things. But you know, I feel like this is a little bit of like a forgotten population in my opinion. I have quite a few friends who identify as being gay men, and they really ask me a lot of questions about it. And you can tell immediately they realize, wow, this is totally out of reach. Um, and I don't know what's been your guys' experience with this, within the fertility clinic and kind of like more broadly outside of it, and like, do we have anything we can do to improve this? I mean, there's a few barriers there, but
Yeah. It's kind of weird. Like, I'm not a specialist. I can't say, but it's actually a community I really enjoy working with. I've been very fortunate to have many either single men. I've had gay men. I've had, couples that maybe aren't married yet, but, and why I really enjoy is because I know as a guy, I can guarantee you if I didn't get married, I would still want a kid. And so I look at that and go, God, what would I have to go through? And so one of the things I've experienced with people is that it's just too expensive. I've had situations where like two doctors who were up in San Francisco, sorry, one's a doctor, that was not, but great guys, make plenty of money, and they were able to have success with two children now, but it was expensive. And when they told me the number, and they were saying they were $200,000 in the first one. I mean, and I think the other thing that we don't think about is if you look at, let's say, like the lesbian community, the sperm donors, right, that they get, there's rarely anything that they have to worry about with being in, let's say, being a lesbian, because they could just go buy sperm and then they have to use their own eggs. They have their own, surrogate themselves. But in the gay community, there are surrogates out there in their thing that says they will not do it for gay men.
Hmm.
And then even the FDA, it was actually a question where we actually just had an FDA visit. And I actually asked them this question of any gay man that makes an embryo, by definition, will be disqualified. And I asked her, I said, even today, they still will not remove that. She actually said that to me. She's like, no, they will not remove that yet. So now you have to tell a surrogate, even if they did all the blood tests ahead of time and they did everything correctly, they are disqualified, which means you have to have a surrogate now sign a waiver saying, hey, we have to tell you you're at higher risk because these men were gay, even if they have no diseases. They're actually no higher risk than anyone else.
right. So they're getting penalized and paying more.
They're getting penalized.
Yeah.
Exactly. So now you have surrogates who might be worried about, well, I don't want this if it's a higher risk. I have to sign this waiver saying that I can get this. You have, again, some people who unfortunately may go, well, I don't want to carry the gay. I think it's a really marginalized community. I think more than anyone knows. I mean, it really is tough. And I mean, $200,000 is a lot of money. I mean, I don't know how many people can afford that. So
I totally agree. And actually, another thing, and perhaps you guys have stats on this, I don't, but anecdotally, I also feel like the twinning rate might be higher amongst gay men, right? Like when you have to spend so much money to get the donor, to generate the embryos, to have the gestational carrier. I think that sometimes folks are really transferring to embryos when it's not indicated because this is their one shot, right?
Mm-hmm.
And so then you've got the increased morbidity for the person carrying the pregnancy, potentially increased risk for, neonatal complications. It's just tough across the board. And yeah, I feel like on a lot of these touch points, it's hard to fix beyond, at least for people that have medical insurance, increasing coverage, but it's a really big problem.
does anyone cover a surrogate? I mean, I know I've seen some say they cover it, but when they say cover, they say like $20,000. I mean, that doesn't even touch it. The average, I think I was just looking up recently that like the average cost to just pay the surrogate is between about 30 to 40,000. Then you have the agencies, and then you have obviously the cost of, insurances now in their insurance say we will not cover obstetrical care for surrogacy, and so now you have to pay for your own medical care. I mean, it is really expensive. So
yeah. I know like some numbers that float around that I hear a lot are between $100,000 and $150,000 for a gestational carrier cycle now, and of course there's a lot of demand by many groups, but it's everybody's sort of vying for a limited number of people who are available, willing to be gestational carriers. So yeah, definitely a group that I hope things get addressed, and I hope there's some improvements in the future as we think about these things, but obviously some limitations. There's a question that I wanted to put out there because it was asked by somebody online here that's watching, and they ask, are there any known differences in fertility diagnoses or outcomes among different racial or ethnic groups? And if so, what might be contributing to those differences? So I'd love to hear your opinion, your thought leadership on this. I know there's been published work, some of it yours, and so would love to hear your take on this.
Yeah, that's a great question. There is a paper. It's from David Safer. Oh, gosh, I'm trying to think who else. Let's see. Yeah, there's it's called Status of Racial Disparities Between Black and White Women Undergoing Assisted Reproduction, and that paper is from 2020, and they essentially looked at SART data over the last several years, and looked at sort of primary diagnoses by race and outcomes and all of those things. And yeah, you can see in that data that women of color, particularly Black women, tend to report or to tend to be reported as having a more tubal factor and uterine factor, and as the primary explanation for their fertility issues. And I believe the paper said white women tended to have more unexplained infertility. So yes, I mean there's kind of good data at the national level that there are different reasons for infertility that kind of segregate by race.
Yeah, and then I guess the follow-up question here is what might be contributing to these differences? So I mean, you said uterine factor. So the first thing that comes to mind for me, of course, well, yes, we know there's a little bit of a higher rate of fibroids among Black women, for example. And we had the fibroid slayer on here not too long ago talking about some of that disparity, and talking about how that affects, of course, Black women of reproductive age. There's definitely research from other parts of the world that shows us there's a little bit more tubal factor issues. Like, for example, in some places with high tuberculosis rates, there's even tuberculosis that can cause scar tissue inside the fallopian tubes, and other types of infectious diseases that can lead to increased tubal factor. But I think what I really wanted to get to on this point is so our field in the US, developed in the UK, everybody's watched Joy now. I think everybody's seen it. We saw where this all started, right? And a lot of the early research is wonderful, but that's what a lot of our field is based on. And a lot of our protocols, a lot of our research on outcomes, I mean, we only had the data about the women that we were treating. And for a long time, they looked a certain way, right? Heterosexual couples, generally more affluent than the average, right? Generally white. And I think the thing that I'm curious about is, has that affected our fields? Is our medicine somehow biased because the group of women we've always been studying or have been studying for a long time, and making our decisions on is that group? And now we have a more diverse group, but we're still applying the same science to it. Or is it, an egg is an egg is an egg?
What do you think, Dr. Amanda?
I think it depends on the outcome that we're talking about, you know. Um, do I think that certain protocols are maybe going to be more beneficial for, a certain race or identity than another? I don't know. Probably not on the margin, but I don't know. Um, just thinking about like the physiology of it, but implantation rates are different, and I think that there very well could, be some, pretty clear differences in like in the uterine milieu that maybe, although, overall like race as a construct, right? Like there's not really a test for a specific race, but there are certain like genes that tend to kind of carry over more in people that are identified by a certain race, and yeah, maybe those genes, when they're expressed in a certain way, do impact the uterine milieu. And so yeah, I think Salam, Dr. Salam, your point is well taken. I think it depends on the question we're asking and whether or not, kind of historically the last 45 years of, IVF technology that's kind of been built around a typically like, white affluent person matters for kind of the greater community. So I don't know.
Yeah, I mean, it's a really great question. That I mean, when you were saying that, I was in my head thinking, "Wow, what a really interesting question." Because you're right. I mean, you look at it in like even like things like hypertension, how you treat hypertension for someone who's Caucasian versus someone who's African American is different, and yet we don't do anything different, right? That we don't, we haven't really done that because most of the patients we take care of, at least for the last 30 years, have been predominantly Caucasian. And what's interesting about it is when you think about it, like you said, uterine issues might be higher, tubal issues. Matter of fact, any low socioeconomic area, right? There's going to be more intercourse happening. Parents are at home, right? So higher risk of sexually transmitted diseases. You talked about fibroids. You can talk about malnutrition. There's so many factors. And I think that's the biggest thing and I think that's the thing Dr. Mann has been saying the whole time too, which I appreciate, is that there's so many things here that I think we can all agree that it can't just be because someone sees someone and treats them always different. That may be true too. We know that's true when it comes to our viewpoints, and making people feel comfortable in following treatment. But that's a really interesting thing you said, because when you said it, that's the first thing that went in my head was, have I ever treated someone different? Not meaning from a race standpoint, but have I ever sat there and said, they're African American, they have a higher risk of having fibroids. Am I more concerned about that? Am I looking for the hydrosalpinx a little bit more? And the question is, maybe I should be, that maybe I need to go, this is a group that's a higher risk, just like when I'm doing someone's history and I find out they have a history of chlamydia remote, and then another one, I go, okay, I got to look more at tubal disease. And it's a really interesting question. I don't know if anyone's done that study. For fun, just so you know, I did do ChatGPT's deep research on this because I wanted to I don't know coming into it. I didn't want to sound like an idiot. So I thought, let me just find out what it said. And what's really interesting is a lot of things we've been talking about. It's a lot of this idea that, we have not done like randomized controlled trials to find out if like one group needs to, have focus on more. Because we do it in certain groups. I'll give you an example. So my Indian patients, I see a lot of Indian patients. And I know for a fact that in Indian patients, there are things we see like metabolic syndrome is going to be higher. It's the reason why a lot of Indian men are type 2 diabetics in our country, even though I'm chubbier than them. The endometriosis is another thing I tend to see a lot more in Indian women. Now, the problem is, I don't know if it's all Indian women. Maybe it's just the ones that come to the United States, right? Maybe there's something different about them. So it's a little bit of a hard study to do. But you really bring up a really interesting point. And it's funny because every group I see, I'll give another one, Asian communities. Every fertility doctor knows when you see someone who's Asian, you're going to do things a little bit different. When you see someone with red hair, you might do things different. And so it's really a great point. And I feel like maybe we should, we got to figure out what those factors are. And to do that, we have to have a larger community to come in. One of the things I saw when I was reading ChatGPT about this research, which again, that's not where I normally do my research, but this is when I just for fun wanted to figure out what would it say. And one of the resources it shows was looking at the different groups and accessing fertility care. So for example, like if you look at Caucasians, say, well, if they ever sought the care, it was as high as 13%. But when you look at the other groups, it was like 7% or less. And the same thing with actually then going through fertility care. For Caucasians, it was in the 62 percentile, and yet in the other ones, it was less than 50%. And then I started thinking about going, well, where do we put fertility clinics? I mean, again, do we go, let's go to this area where it's low economic, where, no, we go, let's go to the places where the rich people live. And so it's kind of interesting that we're creating part of our own problem here. And, I would love to see what Dr. Amanda thinks about, our clinic's a little bit unique. We are a very affordable clinic. And I think that helps us a little bit, for the financial barrier of places. But what do you think of this idea that, like, for us to be successful, we usually need to be around clinic areas that are more financially, let's say, better off. And yet the communities we're trying to help, if we go there, it might be hard for us because then we may actually have a hard time bringing other people there. And so we're kind of creating some of this.
Well, I don't think that we're specifically creating the issue, but I think, and I don't mean to get up on my pedestal here and or in front of a podium or anything, but infertility is a medical condition. It should be covered as a medical condition, right? We should have a federal mandate for this.
100%.
If we did, 100%. And people, regardless of whether they have Medicaid or private insurance or some alternative insurance, had coverage for this, then as providers, we would probably be more successful as we, venture into communities that traditionally have not, accessed REI care frequently. So I guess what the little nuance I'm trying to make here is, like, our field has particularly high carrying costs, or like fixed costs, right? In terms of the IVF lab and personnel, like there are just some economics of like having this sort of practice that we can't change. And, it would be potentially like financially ruinous to go into a community that they can't afford the care, and you can't afford to like not have patients come through the door. And it doesn't help anybody in that regard if you're not, sort of listening to the market. But really the market needs to change, right? Like, infertility is a medical condition. It should be covered. And if it were covered, I think you would see there would be sort of a creep or a crawl into these other communities. I really do think so.
Is there now, though? So, I mean, we have Massachusetts, we have Illinois, right? We have Canada. I wish Steve Rooks would come on tonight. We have Canada. Like, so if that's true, are they there right now? I'm not aware of that. Are any in like areas like that? You're in Illinois. Are there any in certain areas of Chicago that you would be like, oh, or certain areas where you wouldn't expect it to be?
No, in Illinois, like, so it's in the city of Chicago, where most people in Illinois live, is in the Chicagoland area. It is fairly segregated between like the north side tending to be more affluent, and then the south and west sides not so. I do think that there are practices that have ventured out into the south and west sides over the years, really to their credit, and then had to, pull back on those satellites, not seeing enough kind of patient throughput. So I can say I know for sure in Illinois that it has been tried repeatedly, and the economics are not really favorable to make it make sense in the long run. But again, that's why I say, like, part of the issue with the favorability is it's like, well, less people in those areas have fertility coverage, right?
Yeah.
And yes, even though Illinois is a mandated state, it's mandated if you are employed by an employer with 25 people or more, and
Gotcha.
you're not self-insured. So it's actually like, it's great, but it's not perfect, right? If you're self-employed if you're a contractor, if you work part-time, all of those folks are not covered and don't have fertility coverage.
It'd be interesting if they do, if hopefully we, I think what we're like 40 days out from the 90-day, thought process of the current administration. If they do make it a national mandate, or at least can get there, I wonder if that will happen, because, the problem is there's still a business side to it, right? I mean, that's the hard part. Someone has to put up the capital to do it. We don't have, like in Canada, where there's, a federal, let's say, place. And so it's interesting because, like I said, I mean, every place I know is always on the best side of town. And I would be curious to even know, was it a satellite clinic or was it a whole lab that they opened on that side? Because again, now you're talking about bringing other people that way. And so I'm not saying we're creating, I wasn't trying to say it from that standpoint. I'm just saying that, are we really helping it so much? Because, it's almost like, I'm trying to think of an example. Like, if you make this fancy restaurant, you only put on one side of town, right? And you don't ever put on another side of town. It's almost like you're saying to the other side of town that, well, this restaurant is really for you. That's why we only have on the fancy side of town, right?
Yeah.
And so it almost further pushes that idea that, this is for wealthy people. This is for certain kinds. And I don't even know how you could fix that, because there's so much capital that has to go into doing this. And you're right. Like, we have to change the system, and I think everyone has to have access to it, like you said, like a right. And then I'd be interested, then it could work out. I think it would, maybe then, like you said.
This reminds me of the classic, thing with grocery stores, right? You have like food deserts, you have places where traditionally affluent places, they put the fancy, nice place. They have all the, fresh produce and groceries. And actually a lot of times it's the same price as the place across town where the produce isn't so fresh or whatever, and it's not the nice grocery store. But so I certainly agree with what you guys are saying, and I think there, to kind of summarize from my viewpoint, I think there's a geographic barrier, right? Like, I do think that when fertility services, a lot of times, especially for IVF, you're coming to the clinic quite a lot, and so if the nearest clinic is 2 hours away, or even 50 minutes away, and you've got to take the bus or, the L train or whatever it is, to get there, there's going to be a little bit of a barrier. Now, a lot of people make it happen, but definitely something I think we as a field can do a better job at.
Well, I have to say, I am really excited. I can't see the future, but I do feel fairly confident that there are lots of folks in our community that are working to solve the regional problem by leveraging technology to improve access to care. So I think that portion of the conversation, if we're having this talk again in 5 years, I bet you that, those folks in some of those rural communities are going to have better access to fertility services. That's my guess, but I know people are working on it. So I'm excited for the future in that regard.
Yeah, you're right. I mean, we're actually, even like ourselves, are working on different ideas of how to do that. And I think when eventually everything can become remote, I think it changes everything, right? When people don't have to leave their house, and they can just do everything from home, just have to show up one day, I think that's going to change everything, because then the stigma's gone. They don't have to see anyone. Everything's done in the house. And we see it the same with a lot of things, that things can be done at home are going to be done more often, even like abortion, right? If you can take an abortion pill at home, you have more accessibility, you're going to do it, than if you have it where you have to go to the doctor, you have to go across town. Now your family has to understand, where are you going? So yeah, you're right. I mean, I'm hoping you're right. Hoping it's less time, hoping maybe in a couple of years we can see that, but really fun, thought-provoking talks tonight. So
yeah. And thanks for all the people who weighed in. I know some people had some personal stories and some things that they weighed in on. We always love hearing your point of view and your questions that you've been sending us.
Yeah, absolutely. Anything you want to end on, Dr. Amanda? I mean, we really appreciate your time coming on here. Like I said, I'm hoping that, maybe even other doctors who see this or someone might go open their mind up to things. Maybe we can, pressure people into open up some of those other clinics and other places. But anything you'd like to add, or discussion you'd like to end on?
Yeah, I mean, first, thank you for having me on. This has been fantastic. A lovely way to end the night. And I think kind of my parting, thought for the other folks out there would be like to continue the conversation. I feel like sometimes things like this, they're very sexy and interesting and like of the moment, but honestly, like it's a conversation that, you guys could have every single year or every 6 months or,
Yep.
I hope it inspires the folks that are listening to have this conversation in their community, but then have it again, right? Like the question of how do you make your community feel more comfortable and trusting? It's an excellent question. It doesn't have an easy answer. And so I think it's going to take continued conversation and planning and testing to try to get to that answer. So I love that we've had this conversation, and I hope it keeps going.
Well, it sounds like you're already booking your next episode with us, right?
Always happy to come back. You guys are so much fun.
Thanks for coming on. We really appreciate it.
And just to make sure I understand, so your practice, you're working right now there, or it's about ready to open?
It's going to open. So CCRM in Chicago, right in the downtown. We start booking, I think, April 21st, and first inpatient first visit May 19th. So very excited. And I will add, we were really thoughtful about the location, and it's very close to the L, very close to the Metro. And so you don't have to have a car to get here. So
that's awesome. Guys, if you're in Chicago, go check out Dr. Amanda. She's amazing. And thank you so much.
Some of our Fibroid Slayer community that watches as well, please, like, she's right in your town. And, actually that's something we should probably do is get you in touch with the Fibroid Slayer too, because I know that's a big thing is accessibility to fertility care. We were talking about that. We're going to be on his show sometime, and we'll definitely mention your name. Maybe we can get you there with us.
That would be great. So great talking with you guys. Thank you.
Fantastic.
We wish you the best of luck in your practice.
Thank you.
Have a good night.